can pass it on to me or maybe if the time permits. Dr. Basak is there for the last talk, and he will be talking primarily on LipiFlow and LipiView because there are too many regarding the tear film abnormalities and tear film diagnostics. So I've requested him to just focus on LipiView and LipiFlow. Dr. Basak, please.
Thank you, Amit, and I must congratulate Chintan for these wonderful photographs. I mean, mind-blowing, all this. Your whole clinics will change after Cassia 2. This is wonderful, and thank you, Amit, for once again that beautiful and good audience is there. So I'll be talking on tear film diagnostic, mainly on LipiView and LipiFlow. I do not have any financial interest in this presentation. So if you go to the dry eye and MGD prevalence, this is the global prevalence of dry eyes. It varies from 8 to 30%, whereas MGD is between 38 to 68%. And you see that more in Asian population cohort than with Caucasians. If you see the Indian data, there are only 2 or 3 reports are there. One is from our center where the MGD is 37%, whereas dry eye disease is 32%, and one is from northern India where the prevalence is around 40%. So MGD is in the community, especially with aging population. And there are many studies of prevalence of meibomian gland dysfunction at the time of cataract surgery. 52% patient is having MGD, and 56% had meibomian gland atrophy, but 50% of the patient of the MGD, they are asymptomatic patient. This was published in 2018 in JCRS. So there is a direct correlation between cataract surgery and MGD, vice versa. So cataract surgery can worsen MGD dry eye symptoms, whereas MGD dry eye complex causes poor and unsatisfied outcome of cataract surgery. So it is both way, it is important. So there are several mechanisms during surgery, and we all know that frequent fluid irrigation, eye drop, phototoxicity, surgical trauma, incisional nerve damage, all lead to actually ocular surface trauma and increasing the dry eye diseases. And if you see that influence of cataract surgery on meibomian gland dysfunction, the study has shown that alteration of meibomian gland expressibility and TBUT persist for up to 3 months. So most of our patients come back and they say the repeated symptom that eyes burning, itching, sometimes watering. So direct role of cataract surgery by an obstructive mechanism. And the LLT, means lipid layer thickness, was also significantly thinner after cataract surgery, and people have shown that this is also important. You had to look in this. Meta-analysis reports are there. Worsening the symptoms and signs of dry eye observed more frequently patients with pre-existing MGD. So, and we also know the laser refractive surgery, and there is a complex mechanism is happening in laser refractive surgery because of docking, because of laser, because of 360 or SMILE, whatever. So they are also affecting meibomian gland. So ACRS preoperative OSD algorithm is there to for clinical examination in LLPP, look, lift, pull, and push. These 4 important clinical examination is. So we actually have forgotten to check the leads because we are more of cataract focus. So we directly look at the pupil and cataract status of the patient, but you know that the lead is the most important part of our eye. So slit lamp examination, you have to go for lower tear meniscus height, reduced tear leg, mucus strand or debris, slow or no movement of the with the lid movements, and you can also interference fringes of mammalian gland secretion. So, and you can also elicit the toothpaste sign. Right side bottom picture will show that there is toothpaste sign in this. You can use your thumb or a cotton bud to elicit that sign. You can also go for rose bengal, lissamine green and fluorescent stain. And if you see that this is the surface which I cancel for the operation, you see that after doing all the tests, the tests are positive. So you need to treat that patient before doing any cataract or premium IOL surgery. So like, coming to the LipiView and LipiFlow, LipiView, LipiScan. LipiScan there is early modification, earlier version, and LipiView 2 is now current version, and LipiFlow is their treatment section. So LipiView and LipiFlow, initially it was from Tier Sciences, now Johnson & Johnson has no financial interest. There are two components of LipiView system. One is functional component, second one is structural component. So in the functional component, we can see the interferometric lipid layer thickness and blink dynamics. And in the structural component, we can see the infrared mammography with transillumination device. So interferometry, it is just oil in water-like effect. So we can, the lead movement and the thickness and the interference pattern actually calculate the LLT. Normal LLT is 60 nanometer lipid layer thickness. So if you see that the top one is the normal movement, so with the movement is all colored interference pattern, you can look into it. Compared to lower one, when you see this, the movement is sluggish and not so colored like upper one. So the video capturing, you can identify that there is some problem in this lower patient. So height of LLT actually calculated by the software system to know that what is the things are going on. So as I said that normally it is 60 nanometer or more, and also it gives the partial blink ratio. So normally 40% conscious blink, and if it is less than 40%, you have to tell the patient he or she needs conscious blinking training. Whereas the mammography part is direct and dynamic. There are also adaptive transillumination, especially for the lower lid, and dual mode for better contrast for the lower lids. So if you see this in the left side, the gland duct dropout classification, the top one is no dropout, second one is mild gland dropout, third one is moderate, and lowest one is the severe. And in the right hand side, you will see the gland duct dilatation, no dilatation, mild dilatation, moderate dilatation, and severe dilatation. These are almost all clinical. Machine doesn't quantify actually. The other machines have this quantification, but LipiView 2 system doesn't give any quantification of this, how much percentage of dropout or dilatation it cannot give. Summary of reports we get, like this is, you see that Dr. BASAK is here. So average LLT is borderline in one eye, and other eye it is less. Partial blink, 100% partial blink in both the eyes. And if you see the glands, the right eye gland, you see the tortuous irregular glands. Some ducts are also blocked. This right eye, and the left eye you see much less glands. And in the lower lid, there are dropout areas, and I am having MGD, maybe moderate type of MGD that way. So I will show some of the pictures. So you see that this patient had a LLT of 51 and 52 lower. And if you see the lower lid of both eyes, you will see that the gross dropout areas of mammalian glands. Then this is a child of 8 years old who is surprised to see her gland. This we saw, maybe last January or February, for 2 years effect of online classes. And you see that she is having lower lipid layer thickness of less than 40, and lower lid is absolutely, half of the glands are gone. We do not know what will happen when she will be reaching our age. So these are very interesting. Here you see that lower lid and upper lid, both lids drop out area, but there is false high lipid layer thickness. Sometimes patient squeezes their lid just before examination. That time you may find that false lipid layer thickness. And this is also another patient, relatively good gland, but otherwise you see that low LLT, 30 and 25. And again, it could be due to blocked glands, or we are still trying to understand this, what is happening in these eyes, why the machine is not giving. And this patient, 65 years, NS4, asked for multifocal IOL to me, and routinely we are doing for premium IOL surgery, multifocal toric, we are doing lipi view system to see. And you see that in the left eye there is no gland in the lower lid, whereas right eye you can count that there are 2 glands are there. So there is also in the left eye you see the falsely high lipid layer thickness. So a big no to this patient for multifocal IOL. So you have to, this photograph will counsel, very good tool to counsel the patient why we cannot do this thing, multifocal or other PMI. Treatment required for 6 to 12 weeks initially before cataract surgery. If you see any meibomian gland dysfunction, you give warm compress, sodium bicarbonate, Johnson Bart, etc., etc. Topical cyclosporin has got role, mild steroids, erythromycin ointment, and you have to give doxy or oral azithromycin, lid hygiene, everything you have to go for it. And you see that some patient will be doing good, but you have to go for other procedure-based treatment like mechanical gland extraction we used to do earlier, gland probing, it is difficult, LipiFlow, MevoFlow, Cystine, ILAX, and IPL therapy is there. So I'll be talking LipiFlow only, that LipiFlow has a typical constant temperature between 41 to 43, and it applies pressure with 6 psi and 12-minute treatment cycle. Whole procedure requires around, to fitting and all this connection, around 20 minutes, but actual treatment is 12-minute cycle, and it's effective in patient with MGD. And there are the thermal pulsation, heat from inner aspect, and massaging. 3 things goes together in it. So you see that the vault corneal shield is there, lid warmer is there, and silicone inflation massages. The system is like, you can use it only for once, want to plug in. You see that this video, that this kind of movement happens, and it also simultaneously give heat from the inner surface, give compression. So it is just lid spa, you can call it, but it is very, very important that it needs for some patient of MGD. And people have shown that there are improved meibomian gland structure after doing LipiFlow. There are other papers are coming currently because this is a new system for last 5-6 years. So single application of LipiFlow treatment before cataract surgery is effective in alleviating blockage of meibomian gland and preventing the decline of TBUT after cataract surgery. Then preoperative management of MGD is effective and optimum in alleviating obstructive MGD and dry induced by cataract surgery. And following, this is also called thermal pulsation therapy. Actually, the algorithm has been changed. Astigmatism treatment, actually, if you do this treatment, your tear film stability and your final power calculation for multifocal toric may be a little different. So you must follow it, and it is safe and effective after cataract surgery, and also recommend for those whose baseline MGD and prevent development of MGD dry eye for other ocular surgeries also. There are a lot of papers are coming in 2000, from 2017 to till date. So it includes mixed and evaporative dry eye patient, routine preoperative investigation in laser vision correction and multifocal IOL. In our hospital, it is a routine thing. For IT professional, including teachers, students now, because they are spending time more than 8 hours on digital devices. Post-operative patient, both for cataract and laser vision correction after the contact lens intolerant patient. To educate and explain the prognosis to chronic dry eye patient that we could do something and we may not do something. So to whom do we treat? Understand the goal of therapy, willing to modify the lifestyle. This is one part of the tension. The willing to modify lifestyle is very important. The affordability issue is there. May need repeat treatment every 2 to 3 years. So the most suitable candidate is IT worker or using computer for a long duration, visually demanding work. Refractive surgery patient, premium and older patient who actually has obstructive or MGD, blocked dropout gland. So take-home message is good ocular surface is prerequisite for predictable outcome in cataract and laser vision correction. Dry eye and MGD are quite prevalent in our surgery patient population. Pre-procedure detection and treatment gives the optimal outcome. A good for patient prognosis and selection also. Vector thermal pulsation, that is lippy flow system before the procedure, can modify planning and improve your outcome. Thank you very much for your patience hearing.
Thank you, sir, for such a nice talk. And I think we can take 1 or 2 comments or any questions before we wind up the session. One thing that I would like to comment, we have discussed so many of these investigations. We've discussed ray tracing, we've discussed corneal biomechanics, we have discussed the step source OCT, we've discussed corneal tomography, and we've discussed this lippy view and lippy flow. What they say is trash in is trash out. Make sure that when you're getting readings for any instrument, be it a simple biometry, be it an ultrasound, that your reading is reliable. These are eye patients, many of them, sometimes you will do some study and you'll see a reading and then again, the next reading will be totally different from in that patient. We've seen the pentacams and topography maps changing dramatically just because the patient's dry eye was treated. So please keep these things in mind. Machines are very easy to rely on, but we need to have good data which goes into the machine so that it is reliable and we are able to do what is actually good and necessary for the patient. Any other comments before we wind up, sir?
Yes, both all the things are not for our purpose or treatment strategy. These are also important. We used to give the print to the patient.